especially chronic pain, or a lot of the patients that we see are chronic mold exposure, things like that, or more of the true, what you would think of as a little almost medical neurology side sometimes.
Hmm.
But a big thing with that is what I've taken from the patients that I've seen so far is that you have to play this game of you need to be able to tell them what's happening without giving them a diagnosis. They feel like they can make it their whole personality because that's what our brain wants to do. We're in pain and we now know the name to it. That's what all of us want to
And
do.
you're like, oh, I have that.
Right.
Yeah. You're like, that's what identifies me. Yeah.
That's me. Right. And it's not their fault. It's nothing. That's just how life is these days. We want to hook onto that because we're like, now we have an answer because that's what our brain wants. So I try to tell them maybe a little bit of the symptoms, what's actually the system causing some of their symptoms. So I try to basically say, hey, the symptom that you're having, this, your vestibular system is kind of causing you to feel a little off balance whenever you rotate your head because of this, this, and this, right? And I try to integrate not only the systems that's causing it, but other systems we can use to fix it because proprioceptive, vestibular, and eye movements, they're all intertwined very closely. So even though one system might not be working for them, we can use the two other systems to help that one system function better. That way they're not as scared. They're like, oh my gosh, this isn't working. They actually have the answer to how are you going to fix it without making me sick? Because if we just work straight to the vestibular system for a lot of people, it's going to be too much input because any rotation of their head causes them dizziness. So they're like, are you going to rotate me? Something like that, right? So then if you give them the step by step, well, this feeds into that, and kind of explain that system a little bit of how they work together. And so you're going to go through the two systems that don't cause them problems. I find that helps a lot. But it's also, as you're doing that, just taking a lot of time and care to, if they are feeling those symptoms, symptom manage, as well as, like I said a little bit ago, just basically adding something to calm their system down because your fight or flight is what's causing the anxiety, the pain, or the excessive pain, things like that. And so if you can bring that down a little as you're having that talk with them or you're doing the first couple of things, they'll already feel that much better because you're taking the time to explain it to them, as well as actually they're like, oh yeah, my heart rate's gone down, my headache's gotten better, things like that.
Hmm. Yeah. No, I love that. I really enjoyed what you said too about staying away from a diagnosis. That's something that I also like to do. You know, there's other like treatment and diagnosis systems or techniques that actually subscribe to such a thought process as well. Like McKinsey, for example, they really
Mhm.
take a step back from the pathoanatomical and see how their interventions are actually changing the symptoms. And again, and function as well. You know, you got pain, function, symptoms and functioning. If moving the needle on function will kind of move the needle with pain as well. But that's a topic for another day. As far as the pathoanatomical situation, taking a step away because people do like to identify with their quote unquote diagnosis or like imaging findings, for example. But I kind of like to think of it as a functional diagnosis per se, where you're describing what's going on, you're
Mhm.
educating them on what's going on with their body, but you're doing it in a way to where it's, you know, it's not one term or definition that they can potentially be scared of or identify with any potential like fear avoidance they may be going through if this is a chronic pain case, right? So, for example, like when we're talking like MSK, like patient care, it could be like flexion intolerant low back pain, you know, just kind of a general, they're a unique individual. So there's a bunch of details that go into that when it comes to interventions and communication with that, but kind of just giving that functional diagnosis and giving them a game plan and hope for the treatment plan and lay everything out so they can actually have confidence in what they're doing. And, you know, having that from the get-go can automatically just kind of decrease that threat and decrease any sort of hesitation they may have with going to even see a provider.